Okay, I think we can get started here this evening. So hello, everybody, and welcome to NBCA's PEP Talk this evening, uncovering your family health history, the role of genetics and blood clots. Tonight, we are joined by not one, but two blood clot experts, and we're delighted to have both of you here, Dr. Jordan Schaefer, who we've had before, and Dr. Karl Desch, who is a newbie for us, both from the University of Michigan. I'd like to read both of your bios to everybody who is in attendance. Jordan, I'm going to start with you, and Dr. Desch, just so you know, we're very informal here. We go by first names. So I hope you're okay with that. If you're not, then you'll have to exit the Zoom. Kidding.
I'm a pediatrician. We're all formal.
So Dr. Schaefer is from the University of Michigan. He's a member of the National Blood Clot Alliance Council of Emerging Researchers in Thrombosis, although I think you've subsequently graduated from that description. He received his BS from the University of Michigan, his MD from Michigan State, and his MSc from the University of Michigan as well. He is a board certified hematologist and also in medical oncology. Dr. Schaefer, we are delighted to have you here with us, otherwise known as Jordan. Thank you very much for joining us tonight. And Dr. Karl Desch, who is also from the University of Michigan, who is really an expert in pediatrics as well. And so we're delighted to hear what you're going to have to tell us about genomics in pediatrics as it pertains to VTE. Karl received his BS from Indiana University, his MD from Washington University School of Medicine, did his internship in pediatrics at St. Louis Children's Hospital, his residency there as well, and was a clinical fellow at the University of Michigan. We're looking forward to hearing about the Big Bird study, if you have information to share on that as well. He is a clinical lecturer in pediatrics, and you are both so very well published, and we thank you very much for being here this evening. I am also joined by my PEP partner, Todd Robertson. So Todd, thank you also for joining tonight. Okay, just as a reminder before we get started, we just want to make sure everybody knows this is an educational event. We are not here to give medical advice. Every person is different and unique, and you should consult your own doctor for medical advice. So please just remember that. And now I'm going to turn it over to Todd, who is going to introduce our poll questions. Todd?
Great. Those are going to pop up, and I'm going to read them to everybody. And if you guys could just quickly answer them. We use that data. We use those answers. We like to know how you guys feel. And also, we'd love to know your answers on some of these questions. So number one, have you been diagnosed with a genetic blood clotting disorder? Yes or no? If yes, which clotting disorder were you diagnosed with? The antithrombin deficiency, factor V Leiden, protein C deficiency, protein S deficiency, prothrombin G202, or you're not sure. And if you have experienced a blood clot, did your doctor explain that they were testing you for a genetic blood clotting disorder? Yes, no, or unsure. The final question, if you or a family member have a genetic clotting disorder, were you given information to learn about your condition by a clinician? Yes, no, unsure, not applicable. That's it, 4 questions. So if you can read those, answer those, we will see what kind of results we have. If we get those coming through, I'm going to let you know that. Very excited for tonight's PEP Talk because I've been living with an aggressive clotting disorder for a very long time, and I'm looking forward to getting some answers. Here's some results. Have you been diagnosed with a genetic blood clotting disorder? Yes, 39%, 61% says no. If yes, which clotting disorder were you diagnosed with? The antithrombin was 5%, factor V Leiden 26%, very popular, 2% for protein C, 6% for protein S, and the prothrombin G202 was 10%, not applicable, 54%. If you have experienced a blood clot, did your doctor explain that they were testing you for a genetic blood clotting disorder? I didn't know I was being tested genetically, so this is interesting. 50% said yes, 23% said no, 8% were unsure, 20% not applicable. And if you or a family member has a genetic clotting disorder, were you given information to learn about your condition by a clinician? 19% said yes. This is disappointing because 38% said no. 8% on the unsure and 35% on the not applicable. So thanks for answering those questions, folks. Leslie?
Wow, that's, we have a lot of work to do. I think we say this in every single pep
Every
talk.
time, every
We
time.
definitely have a lot of work to do. And we have people this evening from all over the country and frankly, all over the world. Hello to our friends in Australia that are joining us Wednesday morning. Okay. All right. So this is a relatively new area for us. I mean, we talk about the genetic implications for ever, it seems, at NBCA, but the reality is Todd was just talking about, it was what, 1994 that factor V Leiden was actually discovered, which really isn't that long ago. So Jordan, we're going to kick it off with you this evening and talk to us about, so we want to better understand the correlation between blood clots and one's family history and the role that genetics actually do play. Let's bring it back to basics. Can you actually start by explaining what thrombophilia is versus thrombosis, and the difference between acquired and inherited thrombophilia? Then we have a couple of add-on questions to that, but we'll start there.
Okay, yeah, that's a good question, good way to start, and I commend the NVCA for hosting this topic. I think, I think this is often doesn't get the attention that it deserves with patients, and in the midst of a new clotting diagnosis, a lot of the things, are going on, a lot of information is discussed, and often find that patients, even when we've had these discussions, sometimes patients won't remember what their genetic clotting predisposition was, or, the implications of it. So I think it's good to have this review. I have a few slides that I made that might be for people who are more visual, that kind of cover a little bit on this, if that's okay. I'll pull these up here. So I'll try sharing my screen here. Okay. Can you see the slides okay?
Yes.
Okay. So thrombophilia, so here's some disclosure. So thrombophilia, is distinct from thrombosis, refers as a general term for clot, and clots can occur in the veins or in the arteries. Thrombophilia, the root uses the same root for thrombo for clot, and philia referring to loving or a predisposition to clotting. And so most of the time when we're talking about thrombophilia, is that we're often talking about these genetic conditions or hereditary thrombophilias. And that is something in your genetic makeup that you're born with that is associated often with an increased risk of deep vein thrombosis or pulmonary embolism, but there's also a lesser association with arterial clotting and other types of clotting events. So the most common ones we're talking about are the ones that were mentioned, kind of in that opening poll: factor V Leiden gene mutation, prothrombin gene mutation, or deficiencies of one of the natural anticoagulants. And that includes protein C, S, and antithrombin deficiency. So if you're missing one, have less of one of those natural anticoagulants, you'll be more prone to clotting. Potentially, there's some other genes out there that are kind of considerations. And then one thing that's important when we talk about these is, the distinction between heterozygous, or getting one copy of the gene, and homozygous. And so, it's important that if you have, prothrombin gene mutation or factor V Leiden gene mutation, to try to understand from your doctor whether you have one copy, what's referred to as heterozygous. And this, diagram, which is from the Stop the Clot website, shows that, generally that would come from mom or dad. You'd have one parent that would be anticipated to pass on the genetic clotting predisposition to half of their children. And you have one copy of the gene, which is, if you have one copy of the gene or heterozygous, that's a lower clotting risk than somebody who has two copies of the gene, or homozygous for the mutation. And so, if someone has two copies, that means they got, one copy from mom, one copy from dad. And when they went to have children, it'd be anticipated that if their partner had a normal gene, that half of the children would be affected. But briefly, kind of as we discuss this further, it's just important to understand, there's a difference between homozygous, two copies, you got one parent, one from mom and one from dad, that's a higher clotting risk than heterozygous, or one copy. that you got one copy of the genetic mutation from either, parent. So
Jordan, can I ask just a quick question? Do you need to be tested twice? So if you find out you're factor V Leiden, don't you need another test to tell you if you're hetero or homo, or does the one test tell you you've got factor V Leiden and you're this?
yeah. So the one of the screening tests that is done for factor V Leiden is and this is why it's important to go to somebody who's familiar with the testing and what can interfere with the testing, because I often see the testing misapplied. For example, some people check a coagulation factor V activity when they're trying to check for the genetic clotting disorder, and people are told that they're normal. And so sometimes I've seen people falsely told that they have normal results when the doctor tested the wrong thing to begin with. But what you're talking about with the follow-up test is probably activate. So one of the screening tests that's a little bit cheaper, if somebody's not on an anticoagulant, you can check what's called for activated protein C resistance. And if that test comes back abnormal, the confirmatory test, or the follow-up test that's often done, is the genetic molecular testing for factor V Leiden gene mutation, which will give you that heterozygous or homozygous result. Often the clotting panels, people are often tested as part of these panels, and that's sometimes it's just not a lot of discussion. You go in and you have a clot, and your doctor clicks, the panel and tests. The panels, because people are often on an anticoagulant drug when they're coming to see their doctor, the panels often use the molecular testing for the gene mutation directly, which would tell heterozygous or homozygous, rather than that screening test for the activated protein C.
What about the people that use like 23andMe and they say, hey, I've got factor V Leiden because 23andMe said so? Is that accurate? And is that even telling them enough information?
Yeah, it's accurate. It's the exact same test, just done in a different way. So but the problem is, if you and we don't have to get into this too much, but genetic testing should really be done in the setting of some utility of knowing the answers, right?
Right.
And so when you have a blood clot, or risk factors for further blood clots, you could argue that that's the time to get tested to see if that modulates your risk and would direct therapy for you. But when we just want to know if I'm partly from Scotland and partly from Germany and partly from Mexico, then 23andMe is great. But when they start giving you information about genetic predispositions, then it's a little bit troubled, because the utility is very nuanced.
Right.
It will tell you if you're a heterozygous or a homozygous.
I think that's a great comment, and we're going to discuss that a little bit later in our conversation. So just let's come back up onto the highway off the exit for a second here. And Jordan, I know you've gone through the charts and what have you, but what is it that actually does make people clot that have these genetic mutations more easily or more frequently? And what is the role of proteins and how does it actually impact the genetic code?
So the mechanisms of the, detailed mechanisms on how these clots are a little bit distinct, and they have a little bit of, nuance to them. But in general, so like factor V Leiden is a genetic mutation that where the factor V coagulation factor is more resistant to some of the deactivation, processes in the body. So, your body has this complex, regulatory, mechanisms for clotting, kind of like a gas and a brake, so to speak. And so the factor V is a little bit more resistant to the brake, or shutting down the clotting, which predisposes, people to thrombosis. Prothrombin gene mutation, those patients with that mutation will have higher levels of clotting factor 2, or prothrombin, and that can be associated with increased thrombosis. And then the other, the three deficiencies, the protein C, S, and antithrombin deficiency, it's kind of that loss of the, natural anticoagulant. So, for example, let's say a patient has, protein C deficiency and has one copy of a genetic defect in that gene that makes that protein C, which is a natural anticoagulant. whereas most people would have 100% levels of protein C in the blood. A patient might have 50% levels, so they have half the normal level of that natural blood thinner. And so when oftentimes, in that situation, it's not like they just start clotting right away. It could be, that they start the oral contraceptive, or they have the long travel, or, period of immobility, where there's often some other factor that then, tips things over in the body, where they get a deep vein thrombosis and potentially a pulmonary embolism.
Perfect. And so this is really important information for you to have about the patient, so you can make decisions in terms of how they actually get treated.
Yeah, I think there's, three, steps when dealing with clotting. We often, kind of the first step that when I'm seeing patients, I like to know, why did the clot happen? And I kind of think through every potential, risk factor, what's the, family history, what were the circumstances around the clot, what medications were involved, is there any kind of anatomic or structural, predisposition to clotting, like something that was, could have been pushing on the vessel, things like that. And then, then looking at, bleeding risk, and then we try to think about what anticoagulant drug is best and how long should the person be on it.
Okay, great. Todd?
Yeah, so leading into my question, so I've suffered 7 blood clots. We think it's 7, might be more. I don't know. I've lost track. I've got factor V Leiden. I'm homozygous. Didn't know I was homozygous until I was 48 because I had never had a blood clot before. But then once I found out that I was factor V Leiden, then I started connecting the dots, Karl, to why my mom died back in 1984, 10 years before factor V Leiden was discovered, right? So it was a massive sudden death, pulmonary embolism. Then I found out, it's a tough thing to watch a family member die sudden death and then be more worried about, well, she's gone, not think about why she's gone until you yourself start suffering something. And I always, I've always said factor V Leiden didn't kill my mom. The blood clot caused by the perfect storm killed my mom, right? But factor V Leiden, I refer to it as fuel for the fire. But can you share with our audience just one more time? I know that Jordan touched on it a bit, but never hurts to touch on this more than once. Can you share with our audience the difference between heterozygous and homozygous, the difference between having one versus both, and why is it that factor V Leiden is so prevalent in people, especially Caucasians? Why doesn't everyone get a blood clot that carries one or both of these, right?
Those are great questions, Todd, and I'm so sorry to hear about your mom and all the stuff that you've been through. Talking to patients with these things really makes the research that we do more real to us and more urgent. So thank you for that. You're asking a great question. So what Jordan was showing in one of his slides was that, so the humans are organisms that have 2 copies of every gene in their genome, actually sometimes even more, but basically 2 copies of every gene in the genome. And so you've got 2 copies of factor V. One is from your mom and one is from your dad. Very rarely things can happen early on in embryology that means that you get both copies from one parent, but that's super rare. So in general, you get 1 copy from mom and 1 copy from dad. And if mom and dad are both heterozygous for factor V Leiden, which is what I'm assuming is what was the case for you, Todd, that you have a good 50% chance of getting 2 copies. And so when we have 2 different copies of a gene, and they're in the area of our genome that's not one of the sex chromosomes, that means that we make 2 versions of that protein. So heterozygotes for factor V Leiden will make a normal factor V protein that is totally sensitive to inactivation by protein C, and they'll make factor V Leiden, which is more resistant to inactivation. So they might have normal protein levels of factor V, but half of it will be a little bit resistant and more active from a thrombosis standpoint. So that's why homozygotes are generally more affected than, or more at risk for the phenotype, which is the word that we use in genetics to say, like, in this case, the phenotype is deep vein thrombosis and pulmonary embolism.
Mm-hmm.
So yeah, so homozygotes are like that because they have more affected protein in their body,
Sure.
and more likely to lead to the problem.
So Caucasians just seem to have factor V Leiden more.
Yeah, so the story behind factor V Leiden is actually interesting, and you're welcome to tell me to stop rambling and I'm being a little bit
No,
dorky,
keep going.
but
Please do.
it's really interesting. Like, so factor V Leiden is a European founder mutation, meaning that there's a reason why 5% of Caucasians have a copy of this gene. And you'd think that a gene that's bad for you would get sort of selected against over time, over the generations of people. And we certainly see that with variants that are super rare, that they're rare for a reason. It's because they're really bad for you. So what people who are into these kind of questions, the geneticists and epidemiologists, what they try to figure out is why would something that's not necessarily good for you be so prevalent in a population? And there's a couple different reasons. One is that it was really good for you at a time of selection in our population. And we know that, and what I mean by selection is that something that would favor actually having that gene. In a good example of this in something that Jordan's quite familiar with too would be sickle cell disease. Sickle cell disease, when you are a heterozygote for sickle cell, you're not affected by the severe anemia as much, but you're resistant to malaria. And so that resistance to malaria really helps and is an advantage for people living in malaria zones of the world, which is why it's not a Northern European thing, because there's not a lot of malaria up there, but it's more of a Mediterranean and a Northern African problem. So there must have been something about factor V Leiden that was an advantage many, many generations ago. And it's hard to prove because that process may have changed, but things that, were big selective forces in Europe way back when were things like the plague and other big infectious problems. So there are some research out there, I'm not totally familiar with it, that suggests that people who are heterozygous for factor V Leiden are resistant to Yersinia pestis, one of the bugs that causes the plague, and
Interesting.
or other forces like that. So something like that happened.
Sure. Well, so and that last part of the question, so let's just say someone else that I know is homozygous and they're 50 years old and they've never had a blood clot. How can that happen where one person just starts firing off blood clots with the same exact disorder, but the next person doesn't? Is there a reason for that?
Yeah, there certainly is, and it's a subject of intense research in our field, trying to figure out what else do we need to look at to help predict those individuals with factor V Leiden, who's going to actually end up having a problem because of it, or in part because of it, and who isn't. And I think the best way to think about it, at least the way I think about it, is that DVTs and pulmonary embolisms have like maybe about 50 to 60% of it has a genetic influence. And the other 50 to 40% is what Jordan started to describe a little bit, in that a lot of environmental risk factors, immobility, age, pregnancy, all these things that you guys probably know of that are risk factors for provoking a clot. But when people have clots when they're young and when they have clots that are unprovoked, then we begin to get more suspicious that they have something hereditary. And we know you can sort of estimate what the genetics susceptibility is by looking at how often siblings share the same problem. And that gives you a heritability estimate, basically. And we know that clotting is probably around 50 to 60%, like I said.
Okay.
So, but that doesn't mean it's one gene that's causing the problem. It's not all factor V Leiden. And we know that we describe the kind of problems like blood clotting, deep vein thrombosis, and pulmonary embolism as complex genetic traits. And so we know there's a bunch. In fact, there's probably been over 100 different gene loci now in research identified as altering risk for blood clotting, whether protective or putting you at higher risk.
How has that evolved over the last couple of years. And I know we're going to talk about the research that you're doing, but I'm just curious
Yeah.
to how that has evolved.
It's evolved along with sort of improved technology to make it sort of feasible to look at an individual's genome and then look at populations' genomes. So back in really before the 2000s, the best way to figure out if a gene was causing blood clotting was to study families. And we would, I trained with a guy who would, so well known as a geneticist that clinicians would, contact him when they had a family that had multiple affected family members. And what he would do is do some very specific tests of polymorphisms in the genome, so changes in the variation in the genome, and to see where in that family people shared the same maternal or paternal versions of genes, and see how that tracked, and was able to sort of narrow in on where the gene might be that had a mutation that was associated with the disease. Very cumbersome. Took years and years to sort of study families, and the more families you had, the better. The bigger the families, the better. And that's just not really the case in a lot of our societies these days. It's harder and harder to get these big families. But around 2005, the technology for sampling variation throughout the genome really, really improved with the development of this DNA silicone chip technology, where we were now, instead of sampling maybe 20 different polymorphisms in the genome, we could sample 1 million. These were all variants that were fairly common in the population, meaning like factor V Leiden would be on the sort of the lower end of a common variation, being around 5% frequency. But you could sample between, variants that were between about 1% and maybe 50% in the population. And anyway, so that became really feasible. And so these first genome-wide association studies were done. And the first studies in blood clotting that were powered well and had enough people to find it basically found what we already knew. And that was that the major big signal actually wasn't factor V Leiden, it wasn't prothrombin, it was your ABO blood type. And that's something that actually is, we don't think about too much. It's not like you can change your blood type, but being type A or type B is actually a known risk factor for deep vein thrombosis and pulmonary embolism.
Or why doesn't that get more kind of press within the space itself? Because I was just reading about this the other day, and nobody ever mentioned that to me. I mean, I'm unprovoked, which for everybody out there means they just don't know why yet I clotted. But that was never a part of a discussion. And again, I don't want to go too far off the because I want to come back onto some other talking points. But how should a patient actually address that with their clinician?
Well, I think that's a great point. And the other thing that I think we can talk about is that it's hard to know what to do with the information. Because the vast majority of people with type A or type B blood, myself included, so far so good, will never have a deep vein thrombosis or a pulmonary embolism. And the vast majority of people with factor V Leiden will not have a blood clot. So in some respects, it puts the clinician in sort of a difficult circumstance, which Jordan can talk to as well, in that you now have data on your patient. And if they've never had a blood clot, let's say the family members got tested, 23andMe or whatever, what do you do about that? And how do you predict when the increased risk of the people that have type A blood or factor V Leiden is sort of it's a modest increased risk. So probably the reason why ABO doesn't get much hype these days is that there's nothing to do about it. And it doesn't change the way you care for people.
Yeah, but it would be good for clinicians to share, at least with the patient, and say, hey, you should be aware of this. I'm aware of it.
Yeah.
You might not be able to do anything about it right now, but it's potentially a very interesting point as it pertains to their clotting history.
Right. And not just clotting, it's other stuff too.
Yeah, no, this is really fascinating. So I know we've talked about factor V. but there are other types of thrombophilia that exist. And, do these thrombophilias impact races or genders differently, or even age? I know you spend a lot of time in the pediatric space, but, can you talk to us about that? Because a lot of research that has been done historically has been done on whites and white males in particular, but they're not the only individuals that are impacted by thrombophilia. So can you
Yeah.
comment on
The way I think about this is that variants that I was talking about before, and you can stop me if this is too opaque, but variants that are in the population that are common are very much attached to our ancestry, because they're all basically carried down multiple generations in our family tree. That's how they get prevalent in a population, is that they're not eliminated. They arise and they stay in the population for some reason, typically because they don't cause any problems, or maybe they might be good for you. How evolution works. And so there are a lot of ancestral differences, even in ABO frequencies between Africans, Asians, and Europeans. And it is a problem in our community that all the pioneering work was done in European countries with European samples. And so we have so much more data on variation in European populations that it makes it more difficult to use some of these new tools that we have in less common populations where we don't really understand the ancestral footprints as much. So yeah, but when you talk about things that are rare, like things that are sort of, I guess the one way to think about it is factor V Leiden, it's always the same change, just like sickle cell, it's the same mutation. Whereas when you lose function of a protein C protein or antithrombin or protein S, that's usually a different mutation, a mutation that
And
arose only in your family.
Just to reiterate exactly what protein C and what protein S is for the people on the call tonight.
Yeah, there are three major natural anticoagulants in our blood, and these are proteins that are essential for once a clot is initiated, you want it to sort of work locally and not sort of cause the entire circulation to start clotting. And so there's lots of what Jordan described as breaks present in our blood so that thrombin gets inactivated right away after it's made. And there's a burst of activity, a clot is formed, and then it's controlled. And the natural anticoagulants in our blood are very powerful ways of limiting the biochemical reaction that causes blood clotting. And so that's the three major ones we've known about. Protein C and protein S, they sound similar and they work together. And antithrombin works independently and does a bunch of different other things.
Okay, so different populations are impacted, obviously. We just don't have as much data on them.
Yeah, and I guess my point was the rare things where there's mutations that can be all sorts of different mutations, those aren't really ancestral, meaning if they only occur in families, they could occur in any family. Whereas the ones that have really strong ancestral connections are the ones that are more ancestry or population specific.
Okay, so since you've been at this, factor V Leiden, protein C, protein S, antithrombin 3, what else? What else is out there? You've introduced the blood tests.
Yeah. So
blood type today.
When I started in the mid 2000s, that was the sort of the extent of what we knew. There are a lot of groups that use different ways and different methods of saying, hey, maybe this polymorphism is important. One of the great examples of this is the MTHFR variant that we don't test for anymore. But there was a time not that long ago where it was the most frequently ordered test in a lot of hospitals. That's because 30% of the population carry that variant. And so once we started, but that turns out it was a result of a biased way of the way we do research, meaning like there are 20,000 genes out there. And if you're only looking at one variant in one gene, it's hard to know whether it's significant unless you're looking at the whole genome in context. And now we know that when you do these genome-wide association studies, you see that the signal at MTHFR, that gene, is not significant at all in the context. So anyway, so that being said, what we knew when I was starting in 2005 only explained like 30% of the genetic risk, which is a lot actually compared to other problems, but it, completely inadequate for, really the utility of genetic screening in a lot of circumstances. Because again, if you are screen negative, that shouldn't necessarily reassure you that you don't have something that is genetic,
Right.
and vice versa. So yeah, so we started there, and the development of more and more and cheaper genetic testing and bigger studies has done a couple things. One is it's allowed us to identify lots of different genes out there where relatively common genetic variation can alter your risk. But we also learned that the vast majority of these new signals were altering risk very small. And so like I'm talking about fractions of a percentage of risk, but the studies were so big and so statistically powerful that these signals were, easy to detect. And from my standpoint, the biology of this is all interesting too, because these are all signals that we can try to figure out why a variant in this gene that we had no idea had anything to do with clotting might actually be working in the blood clotting system. So we've learned a lot of new biology, and we'll continue to learn lots of new biology. But the utility clinically, I think, is coming, hopefully. But we need actually to learn a lot more. And basically, what we saw was a shift from doing these super small risk common variants to doing more whole genome sequencing. And in whole genome sequencing, you can start to detect these variants that only show up in a person or in a person's family. And those variants tend to, like protein C deficiency, antithrombin deficiency, and protein S deficiency, and those tend to have a much higher risk. We're talking odds of, instead of being like doubling your odds of a rare thing, you're 10 times the odds of a rare thing happening.
So
So
you made an interesting comment before about the lack of large families to test. We have a patient who's one of our thrombambassadors, which is somebody who goes into their community, educates people about blood clots. We have this program that's been very successful. And his family has had a very aggressive clotting history over generations. And they've just now, this is taking place at Yale at under Dr. Lee's.
yeah, Alfred, right.
Yes. And so they've actually started to, identify the gene sequencing for the first time to identify why they're clotting. I mean, it's really groundbreaking work that's going on. If people are on this call want to participate in something like that, how would they do that?
Oh, that's a great question.
They bring up
Actually, I might actually send that to Jordan. Like from a research standpoint, you can always contact me or people like Dr. Lee, who have access and knowledge of how to interrogate a genome and find the gene responsible. It's actually a lot different these days than it was only 10 years ago. But there might be some sort of more organized way that, Jordan, I'm not so sure you're aware of. Probably you'll say, just go to your hematologist.
Yeah, it's a common thing. We do sometimes see families that have multiple generations that kind of stand out that something's going on. We do the standard genetic testing and nothing comes up. But we do have some research, commercially available testing. We often can't, do much more than that. Sometimes there'll be something like there was a clotting disorder that we recently, identified that isn't a genetic disorder, but kind of an autoimmune clotting predisposition that we were able to sort out as kind of a new thrombophilia that we've recently kind of published about. So sometimes we're able to, figure out an acquired clotting predisposition. Otherwise, sometimes I'll work with Dr. Desch and a couple of the other people here we have a research protocol where we can test, family members and a patient and have, people who've clotted and people who haven't clotted, and see if we can identify anything that would, predispose them to clotting on a research basis. But these can't be used for clinical research testing, can't always be used for making clinical decisions, but it's something to help kind of advance things for the future of patient care. So.
Yeah, so there's a lot of big groups of patients that have had funding for whole genome sequencing through the NIH that are trying to address this and sort of we have to have the data out there so that we can interpret it when a patient comes to clinic and gets their genome sequenced in the future. We have to know what to do with all that data and what it all means. So that I'm a part of a couple efforts there, but that's a big challenge for the future for sure.
Okay. Well, I think there are a lot of people who would like to be able to participate and try to get some answers to these questions, because they are important questions to be answered and to protect yourself, but also your family.
Yeah.
So, we'll circle back on that and try to make this available for the folks who would like to participate. In the interest of getting back on the highway, Todd, I want to turn it back over to you. And then we have so many questions that have come in through here that we would love to get to. So at the risk of asking everybody to stay maybe a little bit longer tonight, would love to try to get through some of this, because these are complicated questions that we as patients just don't get answers to. So having the two of you here tonight to try to answer some of this is actually a really big deal for us as patients.
Yeah, and this is great. And Jordan, I want to stick with you because actually this is a nice segue, what we were just talking about, into something I wanted to talk about. A hot button topic for patients and family members who have loved ones impacted by blood clots is genetic testing. Now, and this is super sad and our hearts go out to them, but we've lately talked to two moms who lost their sons to blood clots because they were both factor V Leiden. Nobody in the family knew they carried the mutation until after they had passed. Had they known, their children may very well still be alive, right? What is your view on this? If people do want to get tested, what are the risks to sharing that information? And if you are genetically predisposed to clotting, when should you get your family tested, especially the kids? We so often hear clinicians saying that getting tested would cause undue stress for people, but isn't knowing better than not knowing, Jordan?
Yeah, that's this terrible story. It's my heart goes out to and it I can't imagine being in that situation, but I know if going through that, one of the first things that patients and us as providers go through, because when I'm approaching patient care, I often think about as if each I'm an adult provider, but I think about each patient as if they were my family member. What would I want done for my family? And the thrombophilia testing, what I encourage, and I'll actually pull up my slides again to kind of see, because I think for the audience, I think it's helpful to have some of this knowledge when you're going in to meet with your doctor, so that you can be prepared to kind of have the discussion about the pros. There's pros and cons of testing, and I think that nationally there's probably been a shift away from testing for some of the clotting disorders, and there's some potential reasons. So if it's okay, I'll pull up my slides, some of the slides I had again. So let me see, and that covers a couple kind of tips that might be helpful for patients when they meet their doctor. So one of the things that I didn't cover before is just we talked a lot about hereditary thrombophilia. People often get confused with some of the acquired thrombophilia, which is something that develop over time. And so in general, antiphospholipid antibody syndrome is an acquired thrombophilia. Other acquired things, people use the term differently, but you always got to be careful what you're talking about when you're talking to somebody about thrombophilia. Are they talking about the genetic conditions or some other clotting predisposition?
Jordan, can you just explain for people what antiphospholipid syndrome is?
Yeah, so antiphospholipid antibody syndrome is an autoimmune clotting predisposition, which is very terrifying kind of condition, and it can cause both venous and arterial thrombosis. It can also be associated with pregnancy complications, such as recurrent, pregnancy loss, miscarriage, preeclampsia, early births. And so, these are the things, and oftentimes people will have risk factors for clotting that fall into both categories, that genetic predisposition and then some acquired, factor that might be as well. So we're often trying to think about all these factors in each individual unique patient to make decisions. But, when you're talking to your doctor about thrombophilia, I think it's helpful to know how common is the condition. So, like as we talked about, Caucasians, factor V Leiden, 5% of the population, whereas with antithrombin deficiency, it's much rarer, less than 1%. When you're talking about risk of clotting, there's the risk of the initial clotting episode. And then a lot of times, when we're seeing patients, they've already had the first clot. So, how does this thrombophilia affect my risk of a recurrent clotting episode? And then one thing that's often, a point of confusion is that, these hereditary thrombophilia are more associated with venous clots. So deep vein thrombosis, pulmonary embolism, then, our myocardial heart attacks and ischemic strokes. So the predisposition, tends to be more in deep vein thrombosis, pulmonary embolism, but there is some discussion there. So, when I'm seeing patients, we talk about how common the clotting issue is, what's the risk of an initial clot, what's the risk of a recurrent clot, how does taking an anticoagulant or antiplatelet drug like aspirin affect that risk? Sometimes sometimes people have concerns and get this testing done due to things that pregnancy complications and miscarriages that they have. So we often talk about that. We talk about, sometimes we see patients who have a known thrombophilia that want to know about, what's the risk of hormone replacement therapy with menopause, or what's the risk of oral contraceptive pills. Should family members be tested? And then also interpreting the test results. I, briefly saw some of the things coming in on the chat. Some of these tests aren't reliable when somebody's on an anticoagulant. So, for example, Coumadin and warfarin, affects protein C and protein S levels. So you often can't, check for those, clotting disorders when somebody's taking that medication. So often, some of these medications can change at the time.
False positive or a false negative?
So it will be low. So for somebody who's on warfarin, the protein C and S levels are lowered because it's those are some of the vitamin K dependent factors in the body, and so it would. There's a lot of things that can cause people to commonly see people that have been labeled with one of these, with a disorder, especially for the proteins. Factor V Leiden and prothrombin gene mutation are generally straightforward tests. But as Dr. Desch mentioned, the protein CS and antithrombin can be caused by multiple different mutations. And so the testing isn't entirely straightforward for some of those in terms of the timing. So it's important that doctor is somebody who's familiar doing this testing and interpreting the results, that you can get accurate results. But also we talked about, these exist on a spectrum of, clotting risk. So there's some of these are higher risk clotting disorders, and then some of these are lower risk clotting disorders, such as just one copy for the gene. So I'll kind of skip ahead though for time, but as far as like, why do people come in and want this testing done, is kind of getting back to the original question. So, people want to know something happened that was, a terrible event. They want to know, especially patients that are young or that have an unusual site of their blood clot. So such as a clot around the veins around the brain, a dural venous sinus thrombosis, people that are completely healthy, runners, active, fit, people that are in good health, so some people, ask for testing because they want to know, do they have this genetic risk factor? Some people, are interested in this for, what's the risk of another clot? Is this going to inform any decisions about, in general, we only want to do this testing when it's going to affect how we take care of patients or their families. And so, they want to understand what's the risk for another clot. Is it going to inform decisions about treatment or prevention? For example, say somebody has a known clotting predisposition and they're going to have a knee surgery. Do we have to approach that differently than somebody without that, clotting predisposition?
Mhm.
And then,
They're young. If somebody's family has a history, a genetic predisposition, how young should a child be, or what's the right age to be tested? When should a parent say, "Hey, I want to have my child tested because I want to make sure,
you know,
that
what I encourage people to do is have a detailed discussion about the pros and cons of testing with somebody so when I have patients, I will who ask about their children, I will kind of briefly go through some of the same information that we're kind of talking about today. And what I'll cover too, is I'll skip over this, but some of the cons of testing could include cost. It's not most of the time it's covered by insurance, but for some patients, I've had issues where insurance doesn't cover it. It's expensive. It's actually expensive testing. Whether it's going to change what you do, so like, again, if you have somebody, where it's not, for, let's say, I have a patient that has an adult son, who's healthy and, has it, and they have, to me, it's often important that that the family members know what are the signs and symptoms of a clot, what are the risk factors, and when should I seek medical attention. But if it's not gonna, some of these are just modest risk factors for clotting in the context of several other risk factors. So like for kids, it's often, is it going to change, what we do? Can the testing be done, if they're on other things? I do have a lot of patients that have a lot of anxiety or worry about, testing. I know that you briefly covered that. Sometimes more information is better, but sometimes more information can be concerning for both, patients and other medical providers. For example, I heard of somebody who was, needed a surgery, and again, this isn't somebody that I've cared for, but I just read about this in an article about, the anesthesiologist was worried at a community hospital, was worried about doing the surgery because of the clotting predisposition, and then didn't do, might not do something that they need. So some people overreact to some of the clotting disorders. Having a family history of clotting, even if all your testing comes back negative, can still be associated with a higher risk of clotting. So probably because there's genes that we don't test about or don't know to test about. So sometimes it can provide false reassurance. If all your testing is negative and you have a strong family history, there still might be something going on there. And then there's the risk of overtreatment.
What does that mean in terms of treatment, in terms of anticoagulating somebody?
Yeah, in terms of the the family history.
Yeah.
Well, so it kind of depends on the, context. So I definitely see, have seen, patients where there's definitely a strong predisposition in the family of clotting, multiple generations that have had clotting issues that, are, concerning. Kind of even if all the test results come back, negative, there might be something there. The problem is because that's kind of a rare thing overall, there's not great data. A lot of these, that's the other thing that I was getting at with like how rare these are. So that these things, we don't have a lot of great studies, especially for the rare clotting disorders and everything else, where sometimes we don't 100% have straightforward answers on what to do with the information. Should we, does it change management? Most of the time what drives management was the clot, provoked or unprovoked, or, what was associated with the clotting event itself. Oftentimes that guides our management more than, the testing results.
Mhm.
So yeah, so there's a lot to, and then also some people worry about, sometimes, from what I've been told that, there's can be
Yes,
implications for.
this is a significant concern of people, is the insurance implication.
Yeah, like like I know one of my colleagues, people haven't been able to get like life insurance or had issues with life. I've heard of, stories of even some of my coworkers and stuff, or that have had issues with, life insurance or disability insurance or those kind of things because of some of these test results, whether that's justified or not, sometimes this is a concern. So there are some cons to testing, but yeah, improve, as far as the benefits, improved knowledge of risk, improved education, might help, knowledge for family members. So, I think ultimately, for most patients, I sit down and have almost an hour conversation, often an hour conversation just on this topic, when people are really interested in this about clotting, we've provided the information, we can't change, people's, genetics. And so, often it's a discussion about, how is this going to influence your care? Is this testing, information that you want? We have to figure out the timing of the testing and with respect to any blood clots and, medications and kind of discuss the pros and cons. Oftentimes patients have had this tested by the time they are referred to a hematologist, but, they're when I've had patients where we're having this discussion, I did have a good number of people that, decide not to do the testing after, they read about it and get more information. So ultimately, for your original question about, children, sometimes we'll have people see a pediatric hematologist, especially if they're, under 18 and discuss, in detail the pros and cons of testing and whether it's appropriate or not, rather than just telling people to get, tested. And some of the patients that have told me about, the discussions, again, some people decide to do it, some people don't. And it's often not a rush to do genetic, testing. It's not something that will immediately change. So oftentimes we're dealing with other things and kind of circle back to this, discussion later. One last thing I'll add, though, it is important. It's nice to have as much information for your doctor as possible. So in terms of, often as far as when we're taking a family history, we're often wanting to know first and second degree family members, so parents, children, siblings, grandparents, grandchildren, aunts, uncles, nieces, nephews, who clotted, what age when they clotted, was their clot provoked or unprovoked, or was it associated with a surgery or estrogen or those kind of things. Because how I approach a family member that clotted in their 80s in the setting of immobility and illness and surgery might be different than how I provoked it.
So should an unprovoked person who is below a certain age, should their family members be tested automatically, or do you suggest that?
No, I pretty much don't recommend routine automatic testing necessarily for family members. I think I encourage that I'm trying to think of scenarios where that might be, but generally I encourage people to, at least I do encourage, patients that have a known genetic predisposition to discuss, if they want to share their personal information with their family members. I encourage them to tell their family members about their condition and about educate family members about signs and symptoms of blood clots when they should be evaluated. But, that next level of testing, I think, is something that's best between a physician that has a relationship with the patient and having that discussion about the pros and cons. Because like I said, I often see the wrong test be ordered, or the test being interpreted or misinterpreted, or other, kind of things that can kind of go wrong with the testing. And so I think it's important that people have an informed discussion about whether testing's appropriate for them or not.
Yeah, good point. Okay. So question for you, Karl, and then we're going to just go to some of the questions briefly, because you made a comment about what is the utility of this in terms of being tested vis-a-vis 23andMe. So, I have, I guess, been historically against don't go out and test, like, it's going to stress you out kind of thing. But the reality of the situation is that all of us can go get tested. And so that's just a fact now. I mean, I probably get 10 invites a day on Instagram saying, go get tested for this, go get tested for that. And so isn't there a benefit for people to, if they want to get tested, but go to somebody like you and have the test done so that they can actually have a comprehensive conversation about it versus getting something in the mail. It's not to denigrate any service out there, but it's complicated. And so to have the ability to speak with somebody like you're with Jordan, why not encourage the testing then?
Yeah, it's a complicated answer. I think from a pure human interest standpoint, I can totally understand. I mean, geez, I am a researcher, so I have my genome in the lab somewhere, and everyone is in my lab has their genome. We use it, for research purposes. But like, and people who are really just fascinated about genetics and want to know their family tree and stuff like that, I think there are some utility out there, especially for the 23andMe type stuff. But when we get to like clinical diagnostic genetics, like Jordan was saying, it ain't cheap. It has to be interpreted in a nuanced way, and we simply don't have enough information about um, all the variants out there to be able to confidently say, even when we find something, whether that variant that we found is actually driving a risk for clotting. We have so much more work to do before we're able to sort of comprehensively say, hey, I found a nasty looking mutation in this gene, and we've never seen this mutation before, but other people who have mutations in this gene have this problem. So do you act on that, or do you have to wait for more data to be discovered and I'm not a hematologist, but like the drugs that we use to prevent blood clotting put you at high risk for other nasty thing, which is bleeding. I'm sure all of you who are on anticoagulants have some pretty pictures of bruises and stuff like that too. Obviously it's better than having a pulmonary embolism, which is the why we do it. But doctors don't like to put their patients at risk just in case. And so it really is a complicated question, and it's not a surprise to me that Jordan has to spend a lot amount of time to really talk about the risks and benefits.
Okay. All right. In the interest of time, let's see if we can answer some of these questions. Before we do, I would love to get confirmation that you'll come back and spend more time talking about genetics and the role they play in blood clots, particularly as you get more and more information. And then I also think it would be great if we had a resource, and this is something that we could work with you folks on. What tests should patients be getting? What tests are out there that they should be getting, and what is the role of being on an anticoagulant or coming off of an anticoagulant? There's so many questions out there, but to have that information readily available, our job as PEP is patients educating patients, right? And so we need to make sure that we get this relevant information to the hands of the people who need it the most. So we're going to hold you to coming back. I'm going to jump in first with this for a question, and Todd, we can kind of piggyback off of this, and it's a free for all. So Karl and Jordan, you guys can arm wrestle over who gets to answer the question. My spouse has protein S deficiency and had a massive stroke at 49, followed by pulmonary embolisms. We have 2 teenage children who are refusing to get tested. At what age should they be tested for this genetic clotting disorder?
Oh man. Sad. It's so sad. And such a hard answer. I'm a newborn medicine doctor, so like certainly I think Jordan was mentioning this a little bit, and this is not the full answer here, but there's a difference between you can get genetic testing anytime, right? Because the DNA that you inherit from your parents sticks with you for life, right? And so if you have a mutation in your protein S gene, it's going to be there from day one, right? Even antenatal testing, right? But if you're looking at protein levels or activity of protein S in order to figure out if you have a clinical deficiency, that's a different type of test, right? That's a biochemical test. And then you have to be careful about what age you are and what medicines you're on, because a biochemical test like that is affected by all sorts of other things. But I'll hand off the tough part of that question to you, Jordan.
No, that was a great response, actually.
Would you test the 2 sons if they were willing?
Yeah, that's a good and kind of stepping back from that like specific scenario, but just in general, like how I would approach, somebody with that question in clinic would be first, go through the first, the case of the person who had clotting issues to begin with, make sure that I believe that, that diagnosis is true, and make sure that, like, right, as you mentioned, there can be, other things that cause protein S to go low other than congenital protein S deficiency. And so, then we kind of see is that, in the family. Now that's and then the other thing would want to know the details of the clotting event of the person and, having this discussion about, was that the culprit, is that the, major driving force, is that, we're never 100% sure, and there's often numerous factors involved, but more likely than not. And sometimes, with it, I'm reaching out to organ specialists, if there's a question of, strokes and those kind of things. I'll often, have a multidisciplinary discussion before I even, go back to the patient about, talk to the neurologist, talk to the other people involved, look at the other risk factors, look at as much of the information as I can, and then kind of see. So, okay, so now, we believe there's a protein S deficiency. We believe that that's the culprit for some kind of problem, and then what do we do for the family member, and on the pediatric side, again, this would be one where I'd be kind of, because I'm only done training in adult patients, I don't really see, so I often involve pediatric hematologist to kind of, or even our, sometimes genetics, but often this is, a geneticist, but often this is, discussion is held in the kind of hematology clinic. And then it kind of comes down to the, pros and cons of that testing and how that's going to be. And, for adults, ultimately, it's a decision that, I try to inform, family members on the pros and cons of that testing, and what then allow them to kind of make informed decision. And I encourage them to involve their loved ones or support system as appropriate, to kind of decide if they want to do that testing.
Okay. Todd?
And either one of you, Jordan or Karl, can answer this one. And I'm asking it because it's a question that's come into our support group many, many times. Just want to get your take. Varicose veins, are they genetic? And if you have varicose veins, is it going to increase your clot risk?
I can answer the first part. The varicose veins are highly genetic, and the biggest common genetic variant associated with them is, again, our friend ABO. It's your blood type. So type A and type B are at higher risk for varicose veins. That's why it's so common and it runs in families so strongly.
Great answer. Okay, thanks, Karl. That's all I wanted to know on that one. Leslie?
Okay. Some really fascinating questions here. And again, people are just not getting the answers that they need. Is it possible for siblings to have different clotting disorders, i.e. one sibling has protein S and the other has factor V Leiden?
Yeah, it's in general, people can have multiple clotting defects, and it's not uncommon for me to see patients with factor V Leiden, which in Caucasian populations maybe 5%, but in clotters, in people that are coming to the clinic with clotting, it's even higher. So in the people that I see, a lot of
20%,
people will have, factor V Leiden gene mutation, or, if I tested everybody that, came to a clotting, focused, clinic, it's pretty high. And then, the other genetic clotting predispositions, I have numerous patients that have more than one hereditary thrombophilia. So.
Interesting. Okay.
Another question that comes in, because I think it just kind of confuses people. Don't know if it's because of a genetic mutation, a disorder, or what, but we were talking about that other big ugly thing about this, right? Which is bleeding. No doctor wants their patients to bleed. Patients don't want to bleed. No one likes seeing their own blood. But why is it? Is there any connection here? For example, I'm in the group that doesn't bleed and bruise a whole lot. Why would one person bleed so easily on an anticoagulant, and the next person could maybe have the same injury or the same cut, be on the same anticoagulant, and not bleed nearly as much? Does that have anything to do with a genetic disorder? I mean, why is that? Why can people be so different?
That's
Anyone?
Jordan, do you want to take this? I bet you get this question a lot too.
Yeah. So, again, sometimes we don't entirely, know. There's some people that, have been on an anticoagulant, kind of as you mentioned in your case, Todd, that they've never had any bleeding issues, and then, then they experience a serious, bleed potentially due to some other, kind of thing. And, as you know, our job would be a lot easier if we had, drugs that had, no side effect or risk or anything else that would, perfectly prevent thrombosis. But
Yeah.
none of our drugs are, 100%
Okay.
effective at preventing thrombosis, and all of them are associated with that downside. So any anticoagulant drug has a risk of bleeding, and it can be nuisance bleeding, or it could be something catastrophic. And then they're also not 100% effective. If you look at all the studies, there are clots that occur even though people are, been prescribed, an anticoagulant drug, and that's kind of the challenge. But I think, and this is kind of comes up in this discussion. I try to focus for some people who, have had a clotting event, and this is probably the more common scenario. So if somebody's had a clotting event and they've made the decision, I'd like to be on a blood thinner long term to prevent another episode of clotting events. Let's say, they had an unprovoked clotting event. They've decided to stay on a blood thinner long term to prevent recurrence. Genetic testing isn't really going to change much in what we do, because they've already made the decision. Hey, I've got a lot of risk factors, for clotting again. I don't want to, risk that, and I'm comfortable on the anticoagulant. I don't really bleed much, so I'm not going to do genetic testing because, my decision's kind of already made, and it's not, something. Whereas, where we might be thinking about things is if somebody has a lot of, what we do focus on in clinic is what are the modifiable bleeding risk factors, like high blood
Right.
pressure, fall risk. So, like, sometimes I send people to fall prevention kind of training, and make sure that their eyeglasses are correct and that their vision is good so they don't trip and fall. Blood pressure is good. Avoid unnecessary medicines. We have a lot of people taking, NSAIDs or aspirin, that may or may not be, appropriate for their situation. So what medicines can we reduce to reduce it? So, with all this, we want to focus on what we can fix. Genetics, we can't really change much. So we can try to modify some bleeding risk factors. We can try to make a decision on anticoagulation. And then in some cases, that genetic thing might help us, decide if somebody's, one of those more bleeders, that tends to bleed a little bit more. Sometimes, we'll factor that in if they're, if we'll either try to fix the bleeding sites and make it so that they don't have as much bleeding, or we'll take that into account when we're making a care plan.
Well, one of the things I've learned is it is so patient specific. The whole blood clot anticoagulant, it could just change from one to the other. But the point you brought up earlier, the most important thing, which I'm so glad you've said it a couple times, knowing the symptoms, knowing the risk factors. Managing the risk factors is going to make a big difference. But we should know the symptoms of internal bleed. Or if I butt my head on the cabinet door, do I need to worry about my brain bleeding? People should have those memorized, and that just seems like a good thing to do. But I'm glad you brought those up. So thanks for the answer, Jordan. Leslie?
Okay, I think this unfortunately will be the last question because we've run over our time by a lot, and we will end it here. So back to the genetic questions. I have factor 2 prothrombin gene mutation, APS and MTS. My hematologist says that my 3 DVTs are due to the APS and that the factor 2 is not an issue. Can you help me understand the relative importance of the genetic factor and the acquired ones? I think that's a brilliant question.
Yeah, that's a good, and don't want to comment on a specific, situation, because again, right, I don't have all the details to really, make a, have, but in general, there is some data on all of these genetic and acquired risk factors about the strength of the risk factor, among a bunch of other things that we can kind of think about. There's different risk scores out there, and so there's people have looked at like residual vein obstruction, so how much clot is still on an ultrasound after you have a DVT. The family history, the genetic mutations, the medications, the level of physical activity, weight can be associated with clotting. So we look at, person's, size and, all these various, factors and say, kind of what. And some of these, antiphospholipid antibody syndrome is one where it can have implications for like anticoagulant selection. So, kind of when I think through, why did the clot happen? What drug do we, recommend, and how long do you need to be on it? Some of those, and then, some of the things are associated. We also look at where the clots tend to occur. So antiphospholipid antibody syndrome is one that causes both venous. We often, more commonly see venous and arterial clots, which is concerning. Strokes and, heart, other arterial events are very, all these are concerning factors. So then we have to kind of say which one's going to drive our management out of those factors, or is it a combination of all? And so, antiphospholipid antibody syndrome might be the more, compared to prothrombin, like heterozygous or might be the more, kind of feared one out of those ones. But again, there can be kind of variations. With the rare clotting disorders, which would be more in the protein CS antithrombin, factor V homozygous, prothrombin homozygous, these things are a little bit rarer. There's less good studies. So some of these studies will show one thing, one study will show one thing and the other study will show something different. So that it can be hard to have, solid data with some of these, rare clotting. Protein CS antithrombin, and then the homozygous gene mutations, the studies just aren't as good too. So sometimes it's kind of a judgment call after taking all this into account. So in
yeah,
summary,
I think that speaks to what Todd was saying earlier too, that, every patient is different, even if they have the same deficiency in a protein or the same Leiden variant.
Yep.
There's so many
Yeah.
other things that affect the way these things express themselves.
Yeah. So in summary, we look at it all, we take it all into account. What I do, I'll make a list of everything that, is clotting and everything that might be bleeding, kind of compare those, and then try to gauge, each patient's preferences about how it affects their lifestyle and their job and those kind of things, and then work together to make a care plan that fits the best. So I think, following up with your hematologist or your specialist and making sure that you've had a discussion about, your clotting risk factors and your bleeding risk factors and your personal preferences, and then kind of coming up with a care plan that's good for you is the best overall, strategy. And that takes time. And that's why we can't really have a lot of these conversations, fully in clinic, is because you can see how long this takes to kind of think through all these things. So there's a lot of good resources, online on the National Blood Clot Alliance and other websites too, where you can kind of, it's good to kind of read up on these different things and then bring the specific questions to your doctor to ask about, how is your doctor thinking about, if you have multiple clotting risk factors, ask your doctor about how they're thinking through those different risk factors.
This was absolutely fascinating. Just amazing questions from the audience. I wish we could get to everybody, and wonderful questions that were sent in. The two of you were great. I hope we can get you back in here. Karl, ABO, I can't stop thinking about it now.
That's for
ABO.
sure.
I think there's something for us to do in the future. And really, I think we have an obligation now to really share with patients what tests should be done, what questions they should be asking their doctors. And also, we look forward to hearing about all the research that you folks are doing that we can share with our community. So thank you again for joining us tonight. It was a pleasure.
Thanks so much.